name's Amy, and I did my elective in Cape Town, South Africa. So I'm just going to talk to you a little bit about the things I did when I was there. How do I?
We have to put the arrows to start with, and then it seems to start,
okay.
and it seems to some to the the screen is arrows. Okay.
So on the screen, you just right click up there and it should do. Honestly, when we tried it out, it worked absolutely perfectly.
Thought we've got.
Oh, it's because it should be that one. That's why.
Oh, right there. Okay, cool. So doing the elective is something that I'd been looking forward to since first year of medical school, and I had a few ideas of things that I definitely knew I wanted to get out of it. So I knew I definitely didn't want an observational placement. I knew that I wanted to do something that was hands-on, that would allow me to learn new things, with the opportunity to learn new clinical skills and with exposure to conditions that I wouldn't typically get to see on rotation as a medical student in the UK. So I chose to go to South Africa, specifically to Cape Town. So I spent 3 weeks with the plastic surgery team at Groote Schuur Hospital. I chose plastic surgery because in the UK we don't have a set rotation through plastics at medical school, so I thought that would be a good opportunity to learn some new things in that respect. And then I spent 3 weeks with the paediatric surgery team at Red Cross War Memorial Children's Hospital to get a more generalised view of child healthcare within Cape Town itself. So the specific objectives that I set myself when I went was to become an active member of the healthcare team. I didn't want to just observe, I wanted to be a part of the team and get involved. I wanted to improve my clinical skills, learn more about plastic surgery, and to understand the challenges South Africa faces within healthcare. So just quickly a bit of background about the two hospitals that I went to. So Groote Schuur is a large government-funded teaching hospital in Cape Town that's associated with the University of Cape Town. It's famous as the site of the first successful human heart transplant, and they actually have they've turned the operating theatres and the old A&E where the patient came into a museum that you can actually go around and learn more about Christian Bernard, how he grew up, his surgeries, and the successful transplant itself. But now the hospital has 893 beds. It's a tertiary centre that receives referrals from as far as the Eastern Cape, which can be over a 12-hour drive away. It sees about 50,000 inpatients and 350,000 outpatients per year. I also went to the Red Cross War Memorial Children's Hospital. It's the first and only standalone tertiary hospital in sub-Saharan Africa that's dedicated entirely to child healthcare. It's got 300 beds and it receives referrals from all 9 provinces of South Africa. It also actually has set up a sort of transport system that the buses, for example, from the Eastern Cape, so the buses leave the night before clinic day and they drive through the night with the patients and the patient's parents to arrive the next morning in time for clinics. And often this is the only way that the patients can actually get to the clinics because they don't have private transport. And it treats over 250,000 patients a year. So what did I do when I was there? It was a steep learning curve and it was very different to what I'd experienced in the NHS. So over the 6 weeks, I rotated around various subspecialties within plastics and paediatric surgery. So just to highlight a few things that I did while I was there. So I spent time with the oncological reconstruction team. I learned lots about different types of flaps, the benefits of different flaps, was able to practice lots of suturing. I realised the flap surgeries were good ones to assist on because there was always lots of suturing, especially at the donor site. I also assisted in skin outpatients, assisted in trauma, and saw in particular the paediatric burns team were always grateful for an extra pair of hands because unfortunately there was lots of children that presented with quite extensive burns due to the shack fires in the townships. So there was always lots to do there. They taught me how to do skin grafts and allowed me to do them in theatres as well under supervision. I spent a lot of time with the congenital team, saw cleft palate corrections, and Friday mornings were spent in the clubfoot clinic, where they did the serial casting for the clubfoots. Speaking to the doctors, they said it was very frustrating because they would cast the baby's feet and then say come back in 2-3 weeks time, and come back, the casts were off and the feet were exactly the way they were 3 weeks ago, just because of poor compliance, lack of education as to why the casts were on in the first place. But that's something I'll go into on the next slide. And also, while I was there, the Red Cross Children's Hospital has a paediatric surgical skills training centre, basic laparoscopic psychomotor skills while I was there. So we had to do like time trialed tasks over three tasks 3 times within a certain time limit to gain the qualification. And if you did it within time, you got it. So that was also and so I gained while I was there. So just to highlight a few of the differences that I noticed between the NHS and South African healthcare, and the challenges that comes with healthcare within South Africa. Looking at patient factors, there's 11 national languages spoken in South Africa with a variety of different cultural beliefs. This can cause a massive language barrier, and sometimes you'd be on a ward in a clinic and you'd send someone to find a nurse that spoke the language that the patient did. There was also a lack of patient education with the age of people leaving school a lot younger over there than in the UK, and this was particularly evident for trying to explain congenital or chromosomal abnormalities to parents. When the parents sort of didn't know or understand chromosomes or DNA, it was very difficult to try and explain that what had happened and what needed to be like how to maybe help the child. There was also sort of what I call like an old school attitude towards doctors, which I have experienced in the NHS with like the older generation who have this sort of blanket respect for doctors, and doctors' word goes and what doctors say is always right, and that tended to be the general attitude. Looking at healthcare factors, the main thing that I found was different was a lack of shared decision making. So patients would be seen in clinics. There was no appointment system. They would turn up and be seen in order of arrival. So sometimes patients were waiting 4 or 5 hours to be seen in these clinics. They would be seen by the doctor maybe 2 or 3 minutes max, quickly examined, especially if it was surgical, like a removal of a keloid scar or something like that. Quick examination, booked in for the surgery with no sort of explanation or discussion of the risks. What will happen if you don't do this? It was just, this is the date, come back on that day, please. And that was it. There was no questions asked by the patient, and sort of no explanation offered from the doctors. Looking at government factors, is massively underfunded, and something that I was speaking to the intern doctors, which would be the equivalent of our foundation doctors, is that in order to fully qualify, they have to complete a year's comm service after they do their 2 years of internship. So the only thing I think we have similar is sort of the foundation priority programme, where in the NHS there's incentives to work in typically harder to fill posts, whereas in South Africa, if you want to qualify as a full doctor, you are sent to work in these posts for a year before you can fully qualify. Looking at private and government funded hospitals, there was a massive market for private hospitals, even as far as private ambulances, which would just never happen over here in terms of the ambulances. I don't think some the government ambulances actually wouldn't enter certain areas of South Africa due to the risk to themselves. So if you wanted an ambulance and you're in there, you needed to get a private one. But despite these differences and the lack of funding, both hospitals were academic centres of excellence. So they had supernumerary posts. So I spoke to doctors originally from the UAE, from Switzerland and from America who had come to Cape Town. It was an unpaid but highly competitive post where they, a training post, so they would leave however many years later as a consultant, not paid by the South African government. Sometimes the UAE doctor I spoke to, they were being paid by their own government, but the Swiss and the American doctors were self-funding for the 4 or 5 years that they were there in these posts to become consultants, just because of the training that they would have access to while they were there. What I also learned from speaking to my colleagues while I was there was that Groote Schuur and Red Cross is not representative at all of South Africa as a whole. It's considered a very well-funded hospital compared to maybe some of the ones in Johannesburg or out in the Eastern Cape, where they practiced what they call bush medicine. So particularly in Red Cross, the wards were quite basic, but the theatres themselves were newly done out, had received huge funding for a massive theatre complex, and there was lots of research ongoing there. So it was just quite a stark contrast between the wards and then maybe the townships that were surrounding the hospital to the actual research that was being done within. So just looking at my proposal, I feel like I did become an active member of the team. My clinical skills definitely improved. I was able to practice suturing on most days. I learned a lot more about plastic surgery and had more of an appreciation of the challenges that South Africa faces within its healthcare system. And just as a final note, all the people that I met there were really lovely and really wanted to share their local culture and languages. And one lady that I met taught us that if you say buy a donkey, if it's written phonetically, it sounds like you're saying thanks a lot in Afrikaans. So buy a donkey, and thank you very much for giving me the elective bursary. It really helped, and thank you very much for listening today.
Your choice of elective suggests you're considering a surgical career. Did this reinforce that, or put you off, and has it guided you to
Elective suggests that I would like to do surgery, and has this put me off? Yeah, I'm very interested in surgery, but I'm not really sure specifically which subspecialty within that. I really enjoyed the burns, working with the paediatric burns team actually, so perhaps that's an avenue that will go down, but I really enjoyed the solid time within the surgical environment.
You mentioned bush medicine. Can you tell us a bit more about that?
So I didn't experience any of it, but speaking to the oh, sorry. So can I tell them a bit more about bush medicine? So speaking to some of the doctors who had come to Red Cross in order to sort of learn more to take back to the Eastern Cape, places like London, they said that they just didn't have basic equipment, so syringes or tubing and things like that. So they had a very, they were very innovative about how they did things and how they made things work. So for example, we were in theatre in Red Cross, and they couldn't get, didn't have the right attachment, which was an unusual thing for them to experience there. And the doctor who had previously worked doing bush medicine fashioned a very extensive looking syringe driver into the tube to go into the cannula with various bits of equipment sort of shoved in to make it so it fit properly. So I think it would have been very interesting to be able to go and experience that, I think, but I didn't actually see any of it in Cape Town.
There's certainly a difference between the nicer parts of Cape Town and the townships, isn't there? Did you get a chance to see, you know, the townships at all?
No, so we saw them, sort of drove past them, but my original plan when I went out there was the University of Cape Town runs a student-led group that go out once a week to the townships and runs student-led clinics. There's one doctor who supervises, but the students sort of do a lot of the basic examination history, and sometimes that's the only time that people can actually see the doctors who live there. So I had signed up to do that, but it was cancelled the first 2 weeks because the doctor who had volunteered tested positive with COVID, and then after that it was cancelled again because of load shedding. So there's a lack of electricity basically in South Africa. So every day the electricity is turned off in a part of town for 1 to 2 hours. And you just don't get electricity for those 2 hours of the day. And unfortunately, the time we planned to go to the townships was when the load shedding was on. So it was dark, so not very helpful. But
I think private ambulances might help our paramedic crisis.
Would private ambulances help our paramedic crisis? Supply wise, probably. I'm not sure if it's the best answer to the problem. I think it's really unfortunate from seeing things in South Africa. So one example was like the limit of resources and having to pay for private ambulances. There was 4 paediatric patients who suffered extensive burns, but they were a considerable distance from the Red Cross Children's Hospital, so we needed a helicopter to bring them. Couldn't afford private transport at all, and it was decided that that wasn't the best use of resources to bring the children via helicopter. And unfortunately, when they were treated locally, all 4 died. So it's quite, some of the things that you hear about are,
Thank you very much.
Thank you.